It's just amazing. I just marvel at what technology is able to allow you to do. When you were first studying this, did you imagine that you would be able to perform a procedure such as this with such a tiny stent that opened up like an accordion?
Well, I was really interested in this field because I thought it was amazing that you can kind of go in by remote control into the brain and do all this by looking at cameras and watching these devices in people's heads. But what we can do today has almost no resemblance to what we were able to do when I went into the field. I'll tell you that 10 years ago we couldn't have saved Elizabeth. We just didn't have the technology. And I think a big kudo to what we can do not only goes to the ancillary staff, our nurses and other docs and stuff, but just the engineers, the brilliant people that dream up this stuff, because it's the technology that allows us to do the things that we can never do before. And to be able to apply that technology to do something as precious as saving a life is truly a blessing.
Of course, it's very important for a doctor to be able to determine what type of stroke a patient may be suffering. Indeed, medicine, for example, that might be administered in one type of scenario might be deadly in the other type of scenario. We're going to talk more about stroke treatment as we continue here on Healthline. Welcome back to Healthline. I'm Suzanne Watley along with Greg Rizarian, and we have been talking about stroke, diagnosis, treatment, and we'll also be talking about stroke recovery as we continue with the topic here on Healthline with our two guests, a stroke survivor Elizabeth Manaserian and the doctor who helped save her life, Dr. George Rappard. Dr. Rappard, tell us about how difficult it may be to properly diagnose a stroke. We have the hemorrhagic and we have the ischemic, two different types. If they're mixed up and the treatment for one type is administered in the other case, for example, if you're doing clot busting and someone is suffering the hemorrhagic stroke and they're already bleeding profusely in the brain, that could kill them, couldn't it?
You really have to get it right. And some strokes are pretty obvious. Somebody shows up and they can't move part of their body. You know, there's a 90% likelihood that it's going to be an ischemic stroke, but you still have to do a head CT before you give any clot busting medications, because guess what? If you pop an artery in the brain and you get a blood clot bleeding in the brain over the part of the brain that moves that part of the body, then you're going to get the same symptoms. So what we do is we try and make a determination based on our examination of the patient and then confirm that by doing a CAT scan or an MRI of the brain. Some strokes, though, some stroke syndromes are very, very hard to detect. You've just heard Elizabeth describe how her only symptoms initially were headache. Elizabeth had a stroke due to vasculitis, which is a very rare condition, which is inflammation of the brain arteries, and about 1/3 of those folks present with headaches. Hemorrhagic strokes, about 10% of strokes. The worst kind are subarachnoid hemorrhages, which is a rupture of a brain aneurysm, a little bubble that forms in the brain artery. What is the most common presentation? Headache. What's the second most common presentation? Near death. There's not a lot in between. So we really, as doctors, have to have a very high index of suspicion. When somebody comes to the emergency room and says, "Doctor, I've been having the worst headache of my life," you have to take it seriously. And even though that CAT scan is going to be negative 99% of the time, you might find that one of 100 patients that actually has a leaking aneurysm. So we try to be very thorough and use all the tools at our disposal. And by the way, the most valuable tool is talking to the patient and actually seeing what's going on and listening to the patient and try and come up with the best determination that we can.
Because the more information the patient offers you, the more you have to work with.
That's right. And with stroke, that's where we sometimes come across some difficulty, because sometimes the patients come to you and they can't talk. Sometimes they're unconscious. Right. And we really have to rely on our examination or actually taking a look inside the brain with a CAT scan, which can give us some wonderful pictures that takes actually minutes to produce.
Has anybody else in your family, Elizabeth, suffered from stroke?
Mm-hmm. My grandmother.
So then it is hereditary. And did she have vasculitis as well?
Oh, we don't know. It was many years ago. I'm not sure that they were able to diagnose that.
Is that
correctly.
common? Would you assume, doctor, that since Elizabeth had it and her grandmother had a stroke?
We don't know. Vasculitis, I think, is actually underdiagnosed. I think part of the problem with Elizabeth's diagnosis is when there's when there's a problem going on in the body, you can usually take a blood sample and identify a chemical that's abnormally elevated or reduced in the blood. When you have inflammation of the brain like Elizabeth had, you'll do blood tests and they may be completely negative. And the reason is there's something called the blood-brain barrier. The arteries that go to the brain don't allow anything but energy to be transferred back and forth, and oxygen and CO2. In other words, chemicals in the brain that are abnormally elevated in a condition like vasculitis won't seep into the blood, so when you put a needle in Elizabeth's arm and do a blood test, it'll be negative. And so I think a lot of people that have vasculitis of the brain actually have negative blood tests. In fact, I've treated a handful of vasculitis patients over the years surgically, and I would tell you that I can only think of one person that had an abnormal blood test. All the others we had to treat on instinct.
Now, when someone does present with the symptoms of an ischemic stroke, that means they have the blood clot in the brain, how do you know whether to treat it with drugs that will break up the clot, or whether to go in with the little camera and the catheter to try to either grab it and pull it out or suck it out? And you have a video that you're going to show us of that latter procedure.
I do, and it really depends on timing. Because we've studied it, and we know that at different times, different things are just as effective. So if you can show up within 3 hours of a stroke, we know that we have about a 15% chance of making you better if we inject clot-busting medications into the veins of your arm. If you show up after 3 hours, we think that we can do about as good if we take a catheter between 3 and 6 hours and run it up from the groin artery into the brain and then inject those medications. If it's beyond 6 hours, we think that we can treat you up to 8 hours if we go up into the brain with a catheter that can actually grab or suck out the clot. So it sort of depends on your presentation. But bear in mind, we have a number of tools at our disposal, and it's not all about the timing. If we try something and it's not working, there's something else that we will go to. In this regard, I think the community is very lucky, because Glendale Venice is it's one of a number of stroke centers, but it's also unique in that it's one of only several hospitals in Los Angeles County that has a neuroendovascular surgery program. So in order to be a stroke center, you have to be able to have a program where you can give the IV clot-busting drugs, but we take it one step further, because if that doesn't work, we have resources here, or if you get here beyond 3 hours, we have resources that allow us to actually go up into the brain and remove the clot and try and make you better.
Which thus is a certified stroke team.
That's part of it. We rely on the certified stroke team. That's right.